Hi everyone. So I'm just going to talk a little bit, very briefly, about what we did, and then I'm going to talk to you about the barriers that we came across, the lessons that we learned along the way, and a little bit about what Northwest EHealth is doing to scale this up and to develop from our lessons learned. So as Martin said in the protocol described a broad inclusion criteria and a pragmatic diagnostic criteria. So where are we going to recruit these patients? Well, these patients are primarily treated in primary care, so we should recruit them from primary care. And that isn't the norm necessarily in the UK. We also needed to ensure that the patients had their normal care throughout the study. So that meant minimal intervention and collect their study drug in the same way. So this meant that we would need to work with community pharmacies to understand that the patients were actually collecting their drugs in the normal way. And how are we going to monitor the patients without carrying out frequent reviews? And the way to do that we determined, as you all know, is to use the electronic healthcare system to allow us to monitor the patients for safety and to receive the data for outcomes. So as Martin already said, we were primarily a technology company, but actually a big part of what we had to do was about people. And I can't underestimate enough how big a task this was. We had to engage with practitioners, so the GPs, pharmacists and specialists who were going to be supporting the study. There was an effort to engage with the regulators and payers to make sure that they were happy with the study design, that went through the usual ethical approval, and that the regulators were going to be happy with the outcomes. We had to engage with management systems across the connected community of care. So everybody from the chief executive to the head of R&D to the chief information officer, it was all important because at every level of the organisation, people had to be bought into this process, which wasn't what everybody normally did. It was really quite different. And it's important to remember that for a lot of the people who were involved in supporting this study, carrying out clinical research was not business as usual for them. Your IT department particularly were not normally involved with clinical research. So it was really important to keep the research agenda at the top of their agenda. We also had to create a research delivery team, and with GSK they had to develop a nurse team, and we had to develop a team to manage the processes to look after the data as arrived. And in total, to support this study, 3,000 people were trained to GCP standards. So it's every GP practice, every pharmacist, all the people involved in the study, and all the staff who were directly working on it. In terms of data, we had to build a system to bring this data together. And that system had to be fully validated, as well as the data set had to be fully validated. And we had to develop processes to manage the data flows, which in some cases were on a daily basis, in some cases were on a monthly basis. We had to build a safety reporting tool and deliver this data to the sponsor in a determined format. We also had to do the things that you normally do as part of a clinical trial. So the team had to recruit and manage patients through the study milestones. And we also had to develop processes for data processing, error management, but on a scale that's quite unusual. If in a normal study you might have an ECRF that maybe has 200 data items and you may see the patients 10 times and you've got 1,000 patients. You can do the maths and work out how many data items that is. For the Salford Lung study, the number of data items that needed to be checked on arrival was significantly higher, and it was around the 500 million rows of data that we collected for that study. And alongside all that, we needed to recruit staff who were not the normal kinds of staff. We needed to get technical staff who understood clinical trials, and we needed to manage the audit process as well. So I've got a very simplified diagram of the platform that we built for the Salford Lung study. And as patients are recruited onto the trial, their clinical records were tagged so that we could follow them throughout the study. And we only collected structured and coded data, so we didn't collect any free text. So on the far side, you've got Exeter data, which is from the NHS Spine, that tells you about moves and people changing their name. You've got SUS, which is Secondary Uses Service, which tells you about patient episodes outside your area. And then to Martin's point about the connected community of care, we brought on board 88 GP practices in the areas of Salford and South Manchester. we brought on 140 retail pharmacies who were using, I think, about 8 different IT systems, which were not really designed for this purpose. And that was everything from your kind of Boots and Walgreens down to mom and dad's local pharmacy. We also collected data from out of hours. There was an ECRF as well. So to the points that were made earlier about, is it real world data or an ECRF? Well, actually, it can be both. There was data from community services. And then on the right-hand side, we've got EHR and PAS, and we've got 2 of those. And those are 2 different hospitals that took part in the Salford lung study. One, as Martin described, was Salford Royal, which is a very mature, digitally mature hospital, which has got an enterprise-wide EHR. And the second hospital was the University Hospitals of South Manchester, which is not as mature. We'll just leave it there. But what we did find is that actually, whilst they don't have an enterprise-wide EHR, they do actually have lots of legacy systems. They've got a pathology system, they've got a patient admission system, they've got events, they've got diagnoses. And actually, by going into the back tables of their systems, we were able to extract very much the same data as we were from Salford. And we actually went to other hospitals as well, thinking that we may need to at some point within the trial. And we went to hospitals which were even less mature, or certainly appeared to be, and we certainly could find that data there as well. And then the outputs from the platform, the safety monitoring I'll talk a little bit more about in a moment. There were the study data sets. There was performance management from the ECRF, so we could see how well we were doing against recruitment. And then there was data for the regulators. So just to briefly describe the safety monitoring and reporting. As I mentioned, patients are tagged in the system, and we set up criteria that would alert us to any kind of potential SAEs, serious adverse event. And then there was a safety team that reviewed these on a daily basis from a dashboard, and they're able to go into the EHRs back at source to understand what the causality may be. And then they're reported in the normal way back through to the sponsor and then through to the regulator. Because this was near real time, it was on a daily basis, one of the things that we did discover was that patients may arrive in A&E, for example, on day 1 and get diagnosis A. And then on day 2, after more investigations, they might get diagnosis B. And then on day 3, they might get diagnosis C. And what that resulted in was multiple reports going to the study sponsor and to the regulator. So after a little while, I think it was about 18 months or so, we went to the regulator and said, do you really want all of these? And would you like them batched? And actually they agreed to have them batched. And so they're sent on a less frequent basis. But that means that we've built a safety monitoring tool, an alerting tool, that can be tuned up and tuned down. And we're doing that now with with new clients. So what were the barriers? So I think in terms of barriers, there's a few things that are really important. As Martin mentioned, the connected community of care is absolutely a prerequisite to doing this kind of study. Having all the interactions that the patient may come across within their normal care is really important. And it's really important to have that partnership and leadership to bring that community together. Everybody really needs to be brought into it. To quote an American politician, there are unknown unknowns. And in 2012, there were a lot of unknown unknowns. And I think it's fair to say that all of us that were involved in the study underestimated the scale and complexity of the task. And I'll give you a couple of very brief examples. One was around pharmacy. Pharmacy data hadn't really been used for this purpose before. And we didn't really understand what data systems existed, what they were normally used for, whether the data in them would be any good. And as part of the study, we had 2 attempts at trying to use that data to support the study. If we were to do the study again, we'd probably do it a 3rd way, because that's still a developing area. In terms of understanding the scale and complexity, I have an example around, it was the little things that made this project complex, and things that you didn't expect. When the study started, it was at pre-license phased, and it meant that the study drug name wasn't in a drop-down list in the GP record system. So this meant that the GPs typed it in, which meant that they made mistakes, or they gave it a different name, or they gave it the generic, or they gave it the brand name. And one of the things that we had to do, because we knew this was a time-limited factor, it was only going to be in place until the drug was licensed, we actually had to build an algorithm that would match all of those disparate typed-in names and bring those together. Relationship management's been really important, and recruiting in primary care was a challenge, and making sure that we had the clinicians bought in with peer-to-peer support was really important. So we put in place GP champions and clinician champions to help bring those teams along. And again, I mentioned before, we had to recruit the right staff to deliver this project. People who have a real deep understanding of NHS data and a deep understanding of how clinical trials are done. So, lessons learned. This is really disruptive. One of the things that we've already started to deploy with our new clients is making sure that the entire study team from the sponsor is involved as early as possible, because the disruption to their ways of normal working, to their traditions, is actually all-encompassing. And a good example is around the statistics team, who often don't get an active part in the study till towards the end, but we're involving them really early at the beginning. It's really important to get the right data. More data isn't always the answer. It needs to be the right data, with the right provenance, with the right frequency, because if you don't need it every day, don't get it every day. I think it was Daniel that said data costs money, and it does, because we've still got to manage the data processing. And only collect what data you need from outside the EHR. If you create duplicates, so if the data exists in the EHR and then you go and copy it again and collect it in an ECRF, you're going to create a challenge for yourself around source data validation, which could create huge inefficiencies. So what are we doing to scale up what we've done? Well, we've moved to NHS cloud infrastructure, which means scaling up is much quicker and much more cost-effective. The platform that we built has been fully re-engineered and revalidated, and it now has configurable and modular applications. So if you want to do a full pragmatic RCT, you can use all the applications. If you want to do a late phase study, you may only want to use a few of them. We've also developed our own master data management system, which allows us to develop configurable data schema and data dictionaries more quickly than we have done in the past. And we're extending the data footprint, bringing online more hospitals, more GPs, and better pharmacy data, working with NHS Digital. And as been mentioned quite a lot today, we're looking at new data sources around wearables, genomics, and social care data, which is sort of data that happens to patients in the community that doesn't necessarily involve a clinician. Where are we going? Well, as everyone's talked about today, we want to be able to create these connected communities of care in the UK, in the US, and elsewhere. We're looking to bring in standards, and we want to understand how we can get to a position where everybody is collecting the same standard of data and how we can develop that interoperability. So our new platform looks like this. It's very similar to the old one, but down the side we have all the new potential sources of data, and around it are a whole new suite of APIs.